To make a very important point before I start and introduce my the IC that we have today. For all refractive surgeons, one thing we do is we begin in time and we end on time. So that is a hallmark of all refractive surgeons, and I'm sure this small crowd that we have is going to be that leading edge of the refractive surgeons. So let's clap for all of us, because we have come here first on the first day and we are here in the first session. So phakic IOL, learn it from the masters, and it gives me really great pleasure to introduce our masters in this course of phakic IOL, Dr. Purendra Bhasin, overview and workup of phakic IOL. He'll take us through the most important part of phakic IOL, because if a workup is done well, then the next parts are very easy. And I will show you the least important part and how to do an ICL and a toric ICL the correct way. Dr. Ramamurthy will take up IPCL, and that's a very important topic because this is for the Indian scenario. Not all our patients can afford ICL, and the expenses are huge for a patient with ICL. Dr. Sri Ganesh, who is here with me and from Netradhama, Bangalore, he has had a wide experience, a huge experience of phakic IOLs, and he'll show you the challenging cases and how phakic IOL can be of use in such cases. And we have the boss, Dr. Mahipal Sachdev, speaking of ICL in complex situations. So we have the whole menu before you, and please interact with our speakers. We have allotted specific time, and we will be sticking to time for our talks, and we'll be sticking also to the part that we have been assigned. And we have left a lot of time for interaction, so please feel free to interact and ask all your questions and clear all your doubts. So I call upon Dr. Bhasin, who is from Gwalior, a great friend of mine and one of the most seasoned phakic IOL surgeons of the country. Dr. Purendra Bhasin.
Thank you, Dr. Partha, for this nice introduction and for giving me this opportunity. I will be dealing with the overview and workup of phakic IOL. I can see the enthusiasm of the persons, delegates over here, coming for the very first session on the very first day at the very early morning. And with this, very good morning to you all, and I continue with my talk on overview and workup of phakic IOL. It's a good and safe option for LASIK rejects. It's not coming over there. Some issue there.
Can someone close the door? Darwaza band kar do bhaiya.
Abhi aaya tha. It is a good and safe option for LASIK rejects. It allows the crystalline lens to retain its function, and there is less risk of vitreoretinal side effects of clear lens extraction, faster recovery and healing. It does not cut or remove any corneal tissue. Cornea retains its natural shape. There is less glare issues on patients with large pupils, especially with the ICL, and very stable over time. There is no regression. So we are having three types of available phakic IOLs in our armamentarium. Angle supported phakic IOLs, iris fixed phakic IOLs, and posterior chamber phakic IOL. 1953, Strampelli, and he came out with the angle fixated the phakic IOL for the first time. Then Barrecker lenses, Backoff came out with the angle supported lens. Wirsch Fechner in 1986 came out with the iris fixated lens. Then the various generation of angle fixated Backoff's lens was made, and New Vita lens. But all these angle supported and iris fixated lens has lost their glory because of the complications and the resulting endothelial cell loss mainly, and the damage to the blood aqueous barrier and uveitis and formation of cataract. Then there are various other varieties, that is angle supported from eye care and other. Currently, we are having three types of IOL which are FDA approved. Iris fixed Verisize phakic IOL. It's FDA approved for myopia, made up of PMMA material, highly predictable and relatively safe. It requires large incision from 5.5 to 6 millimeter. There is an endothelial cell loss present with this, and but to not much extent. And there is an edge glare because the sizing is an issue. Optical, if the pupil size is more, then there is an edge glare. And as you can see here, there is a chance of disinclination. We did it some 15 years back. We did this kind of lenses, and this is from our own patient. This photograph is, wherein you can see this haptic has disinclinated, and this is there. So we have replaced it with the present generation posterior chamber phakic IOL, that is ICL, some 5 years back. I am doing ICL for last 9 years now. This is another Veriflex lens, which is a foldable, flexible model of the Verisize, but it has not become very popular because of the various reasons, and it is not FDA approved too. Then Alcon came out with the AIOC Cache phakic IOL. This is again an angle supported lens, and very good optical quality, but it is not FDA approved yet, and it has not become very popular because of the angle supported model. Secondly, it is visible. Thirdly, it produces uveitis, and lastly, I should say there is an issue of cost. It is quite expensive. As has been said by Dr. Partha, IPCL from the CARE group we are using for last 2 years now. It is made up of foldable hybrid acrylic material. The lens has a vault and similar to the ICL, and is customized according to shape and size of the eyes, similar to the ICL. The overall size is from 11.5 to 14 millimeter in 0.25 millimeter steps. It ranges the power from plus 15 to minus 30 diopters with cylinder correction up to 8 diopters. It could be inserted through 2.8 millimeter incision. There are 4 plus 2 holes. These are 4 holes plus 2 holes to balance the aqueous flow in the anterior chamber, but still it requires PI. It is mandatory in all cases. We will focus here mainly on the implantable collamer lens from Star, that is ICL. It is made up of collamer material. It has got it absorbs the ultraviolet radiation. There is a central vault, as you can see here in this shape, and it is a foldable variety, but there is a issue of sizing if we have not measured the white to white preoperatively correctly. The long-term proven phakic IOLs today available are ICL, which is FDA approved, Verisize, which is again FDA approved, but it is not very popular now. I don't think any of us are doing this now, and AIOC Cache, which is CE mark but not the FDA approved. The advantage of ICL over others are with LASIK and Verisize that aesthetically it is pleasing. It is not visible because it is behind the iris and not visible. The artisan lenses are visible and LASIK is not visible. Incision size required is 3.2. With Verisize it was 5 to 6 millimeter, and LASIK flaps are from 7 to 9.5 millimeter. Safely located away from endothelium. It is near the endothelium. Chances of damage to endothelium are there. There are cuts through cornea which can induce higher order aberration. PIs are not required with Vision new generation centraflow lenses, and with the Artisan it was required. It is made up of biocompatible collamer material. This Artisan lenses or Verisize lenses are made up of PMA material. Future treatment options are preserved with centraflow Vision ICL. It is also preserved with the Verisize, but with LASIK we can do the enhancement procedure if the corneal thickness is adequate, and it is reversible or removable. The ICL Artisan lenses are also removable or exchangeable, but LASIK is not a reversible procedure. So, and we can do it. The learning curve is not much as with the ICL. With Artisan, it is a longer learning curve and longer surgery duration. With LASIK also, it is not much a learning curve. So coming to the workup part, The advantages of ICL material is that it is made up of a collagen material. So collamer, with this, when it is placed inside the eye, it attracts or invites a fibronectin layer in front of it, and this repels the proteins. The layer of fibronectin on the surface of lens inhibits the deposition of other proteins. So the material remains very clear even in the long term, and there are no chances of presence of the precipitates over the lens. The collamer lens is not recognized as a foreign body. As you can see here, the picture, the silicon lens with protein deposition, it appears as if it is on the right side, and there is no protein deposition even in the long term with the collamer lenses. This material has a maximum light transmission because the molecular size is very less, shorter than wavelength of light, better optical performance, excellent transmittance, and low reflectance pattern. The quality of vision with the ICL is phenomenal. Very flexible, foldable design. It can be inserted through a small incision, easy to inject and remove, and there is a less glare and halos. It is available from to correct minus 0.5 to minus 18 diopters of myopia with plus 6 diopters, 0.5 to plus 6 diopters of cylindrical correction. It is available in the steps of 0.25 diopters from minus 2.75 to minus 0.5, and above that it is available in 0.5 diopter, 0.5 diopter variation. It is indicated in cases of, mostly we do in cases of LASIK rejects due to high myopia, when there is a thin cornea less than 500 micron, there is a dry eye patient, large pupil size, excessively flat or steep cornea is there. It is done in cases above 21 and up to 45 years of age we have done, and when the refraction is stable, there is no change in refraction for more than 0.5 diopter in last 1 year. No previous ophthalmic surgery, especially corneal refractive surgery, but I think this is now a relative contraindication, and there is no previous ocular pathology like cataract, keratoconus. Keratoconus is relative now because we have done in lot many keratoconus patient after CXL treatment, after managing it, and stabilization of the refractive error. In the presence of glaucoma, Fuchs dystrophy, uveitis, or any other corneal pathology. A complete ophthalmological assessment is done like in any other surgical procedure. Uncorrected and best corrected visual acuity is noted. Refraction manifest and cycloplegic is must. It should be done in all cases, otherwise there is a chance of over or under correction. A slit lamp examination to assess the status of tear film, right from the lids, meibomian gland, tear film, cornea, lens, and everything has to be assessed on the slit lamp. Endothelial cell count should be more than 2,000 cells, and there should not be a glaucoma or raised intraocular pressure. Angles should be wide open. We should do gonioscopy in all our cases. Fundus examination, detailed fundus examination right up to the periphery by the retina specialist should be done, and any lesion in the periphery, suspected lesion in the periphery or hole has to be managed before, and a laser has to be done for that. Anterior chamber depth should be more than or equal to 2.8 millimeter excluding the thickness of cornea. This is very, very important indication, and this has to be kept in mind, and we have to do the anterior chamber depth measurement in all these cases. We do corneal topography and keratometry in all these cases to rule out any other corneal subtle pathologies like keratoconus, and corneal horizontal white to white distance measurement. This is again new to this. Accurate preoperative white to white and AC depth measurement is very important. And ICL provides a vault, as you can see here. This is from our own library, own picture with the pentacam. This is the lens, ICL, and this is the crystalline lens. So this distance between the ICL and the crystalline lens is the vault, which we call as. And you can see on the A scan, this is the anterior, the ICL line, and this is the line of the crystalline line. So there should be a clear-cut distance between the two, and it can easily be seen or measured at the slit lamp. ICL provides a vault. This is the distance, as I said, which is ideal. One is from 0.25 to 0.75 millimeter. How to measure it? You can compare it with the thickness of the cornea on the slit lamp. And you can see, say if we assume that the thickness of cornea is 500 micron, so it should be between half of the corneal thickness, that is 250 micron, to 1.5 times the corneal thickness, that is 750 microns. This should be the ideal thickness, and this can be measured on OCT also, and anterior segment OCT also, this can be measured. So it should be half the corneal thickness to 1.5 times of the corneal thickness. In an undersized ICL, if it is less than 0.125 millimeter, that is less than half the thickness of the cornea, there is an increased risk of anterior subcapsular cataract. And in an oversized ICL, that is if the vault is more than 1 millimeter, that is 1000 millimeter, it pushes the iris forward and closes the angles which could lead to IOP rise. This can happen, and we have done in our cases, we have done in one case, we have exchanged the lens because the vault was very high, more than 1000 millimeter. So, and this is very good that we should, that this is a reversible procedure and the patient are happy after that. Then white to white, how to measure the white to white, because this is a very important thing. So it should be measured either with the caliper, or this is a digital caliper. These are available in the market, and the ICL company and even the IPCL company, they provided. We should calibrate the caliper before use every time. And the measurement is done under the microscope, under topical anesthesia. This is how a small video is there. And this is with the digital caliper. You can see these are the measurement which we are doing white to white. And it's 11.16 millimeter. It's very simple. It hardly takes more than a minute. It takes less than that, and you can easily do it under topical anesthesia if the patient is very cooperative, and this gives the practice to the patient also that the surgery also is done in a similar way and under topical anesthesia. So the white to white can be measured through various instruments like OCT also does, and the OB scan and pentacam also give us but that is approximate. The real thing is to be done with the digital or the caliper which we are having in our operation room every time. And that can be measured on the steel scale which is available in the market. That also can be sterilized. So,
we are...
so I will just, just 1 minute. ICL has got a central opening. This is a central flow. ICL belongs to the ICL V4 family. It is stored in BSS. And this opening is of 360 microns. It is designed to restore the more natural aqueous flow and eliminate the need for iridotomies. And there are 2 more ports on the either side of the same size. And these perioptic ports are designed to remove the viscoelastic. And in case it is helpful to provide the redundancy, means you can remove, if the central port is closed, the peripheral ports can be used for the aqueous flow from the in front and behind. And iridotomy should be done. This is done with the YAG laser, as you can see here, 1 to 2 weeks prior to surgery, or intraoperatively. It can be done with the help of a retractor. I prefer to do intraoperatively. And the marking of the horizontal axis at the lamps, at the slit lamp, can be done as we do it with the toric IOL. This is for the toric lenses. And you can make such kind of marks with the pen at 90 degree and 180 degree, or you can use a bubble marker with the bubble in the center of 2 lines and mark it in a patient in a sitting position, as we do it with any other toric IOL. So with this, I stop here, and surgical technique will be dealt by the course instructor, Dr. Partha Biswas. And I thank you for the patient hearing. Any questions will be taken at the end of this.
Thank you, Purendra. And I think this was one of the most important parts of the whole ICL or IPCL or a phakic IOL surgery. If the workup has been done well, the surgery will be done well, and the outcomes are excellent. So we'll take a few questions, and Purendra has touched upon very, very important points, and we'll just go through those points once again. And after this talk, I think we'll take the questions for the first 2 talks. Before I begin, how many of us are doing phakic IOLs? Can we have a show of hands? Okay. Wonderful. I mean, this is exactly what we wanted. We have to be a mix of people who are doing phakic IOLs and those who are still about to start, so that we can take home messages that how do we start, or for already the seasoned people, what are the new things that we can share amongst ourselves. So the correct way to do, can you put it on please, this side? Yeah. So the correct way to do an ICL and a toric ICL. So this is a very important part. It's a very swift surgery, but it has to be done very precisely. It has to be done repeatably, and there should not be hassles to it. So this is the lens that we have been talking about, and I'll be dealing with the ICL only. And as Purendra showed the marking, so I'm going to take you through the markings once again. Once you have put your markings on the patient's eye, sitting in the sitting posture, then when the patient is on the bed, you need to do the alignment of the axis. And the alignment of the axis is important because all these patients are patients under topical anesthesia. They tend to move, but your alignment has to be very good. The markings have to be visible so that when the ICL is there in place, you can align and see whether the toricity is well maintained or not. Because if there is a change in the toricity, then the whole intention of doing a toric ICL is lost. So let's come to the most important part of the doing of an ICL, and that's the loading of the ICL. Implanting the ICL is not so important as is the loading, because if it is loaded well, then the ICL can go in very smoothly, and it just takes about 2 minutes to go in. So the ICL, once it is loaded, it has to have a proper forceps with which it is handled, and this is called the os deur forceps, or the front loading forceps. This is supplied by the manufacturer, and let us all use this. Let us keep it well, and let us maintain it well, because these have very, very fine markings to grasp the ICL, and your theatre assistant should maintain it well so that rust or particles do not accumulate between the forceps of the ICL. The foam tip applicator, which comes along with the ICL, is a very important tool, and the foam tip applicator is something that you have to use. Please do not use anything else but this foam tip applicator, which is of a perfect size to load the ICL. And it has to be well hydrated when it touches the ICL, because the ICL itself is extremely thin, ranging from about 50 microns to 250 microns. So you can understand the delicacy with which it has to be touched. And this foam tip applicator should be well hydrated before you touch the ICL with it. The landmarks on the cartridge is very important. The cartridge, again, is a very special cartridge supplied by the manufacturer. It has an edge or a lip, and it has a flat loading dock. Can you use this cartridge again? You can, but it is something that is best not done. The next thing is filling up of this cartridge before you touch the ICL with BSS and viscoelastic methyl cellulose. So the fill into the cartridge is also important. The fill is half with BSS and half with methyl cellulose, so that there's a half quantity of each. And the ICL itself is made up of Collamer material, which is a hydrophilic collagen copolymer, and it comes packaged in BSS. So when it comes packaged in BSS, it used to come packaged with sodium chloride, a normal saline, initially in the previous designs. So then it used to open up, and it used to change its dimensions inside the eye. And therefore, on the first post-operative day or even after 6 hours of the surgery, one did not know whether the ICL is in its proper position and whether the vaulting of the ICL was precise. This used to come up only on the third or the fourth day when the dimensions were what it was in the eye. Now it comes packaged in BSS, and this is definitely a very big advantage to all of us. So you need, once the ICL is taken out, you need to know the leading right and the lower left. These have to be aligned because the vault of the ICL is important, and the ICL, the greatest concern of a surgeon doing an ICL is the ICL should open the right way up and not upside down. So this is the greatest concern while doing the ICL. So we need to slide out the ICL with the foam-tipped applicator, and the edge of the ICL, it has to hinge on the edge, and you have to be very careful because the manufacturer never provides a backup lens. So if you drop your ICL on the floor, that's finished, and you have to postpone the surgery to get a next lens. So this is, again, the proper orientation of the cartridge should be ensured, and the lens has to be pulled along the cartridge very, very gently so that it does not tear the ICL. Because as I said, that the thinness of the ICL is just about 50 microns in the optic part, and the thickest part is about 250 microns. So the loading, again, the ICL should be oriented properly in the cartridge, and once it is in the cartridge and is in the nozzle, one needs to check under the microscope so that you can identify whether it's well loaded or poorly loaded. If it is well loaded, it will just be a rounded off and straight and smooth, and if it has a crumpled appearance, which means it is very poorly loaded. So it goes into the cartridge, into the injector, and the injector has to be clipped on. And once it is clipped on, you need to express the ICL a little further so that you know that the foam-tipped applicator is actually pushing it very well, and there will not be hiccups when you insert it into the eye. So we'll just run through this small video, and this is how we are putting in the viscoelastic, methyl cellulose, and then the BSS, and taking out the ICL. It must be done over either the table or the eye so that you prevent it. And you can see that I'm tweezing it inside, and the edge is coming on, and you can see the vault. It's very important to maintain this convexity upwards, and a gentle pull. You can see that the cartridge is slipping on the so the pull has to be very, very gentle. The cartridge actually has to slip out, and the nozzle and the forceps has to slip out as well. So these two forces, you can see that the cartridge, I'm pulling it out, and the forceps withdrawing it. So, and you can see that it has rolled up very well, and it is inside now we have put it into the injector, and this is ready to start. Now for the ICL insertion, two side ports are made, and these side ports have to be made. Now this placement of the viscoelastic is also very important. Just the amount of viscoelastic has to be just adequate, and I stopped it here just to show you that the streams of the viscoelastic should merge with each other, and that's the optimal point where you should know that it is a good fill. It should not overfill, and it should not be underfilled. So after that, you make your entry. At times, if you lose a little bit of the viscoelastic, put in a little more viscoelastic and then continue. As a matter of habit, tap the globe a little just to estimate the tenseness of the globe before I insert. Now, while inserting, this is the most important part, and as you can see now that the ICL is folding out, and the ICL has not folded out perfectly centrally. So what I'll do is I will rotate the nozzle a little, and see, I'm rotating the nozzle, and now it is folding out quite well. So once it folds out, see, it has gone to the upper portion, but the folding out and the unfolding is quite appropriate. So now we need to, this is the manipulator which has to be used, again supplied by the manufacturer, and the four feet of the ICL have to go under the iris. Can you directly place the ICL in the sulcus directly? Never do it, because it is actually the foot plates of the ICL which have to be tucked under the iris, and that is the right way, because if you directly try and put it under the iris in the first go, you might injure the zonules. The next part is the proximal foot plates, and these have to go in. Again, I'll just stop it here. Now, you can lose a little bit of viscoelastic on purpose just before attempting to put in the foot plates which are proximal, and thereby the iris comes up a little. Now, one practical problem that you might face, if it is too tense with the viscoelastic, then what happens? The ICL, the pupil dilates out too wide, and you might not be able to see the edge of the pupil. What to do? Drain out a little bit of the viscoelastic, the pupil will come down a little, and you will have just the adequate amount of the edge under which you should put in. Again, if the pupil is constricting, then put in more viscoelastic, try and stretch out the pupil with the viscoelastic, and that also works quite well. And again, aligning it. Now, this is again a very important part, removal of the visco after placement of the ICL. The removal of the visco has to be very adequate, and what you can see, I'm using the bimanual and have taken the irrigation, and I'm on the centra flow, meaning that the irrigation is going through the centra flow and the fluid is coming out from the side port, and the aspiration is at the side. So that adequately removes the viscoelastic from the space between the ICL and the crystalline lens. And this has to be done very gently. You should avoid touching the optic part of the ICL, and as I said, it is just 50 microns thick, so this has to be taken into account. The ports are 360 microns large, and it is very necessary to ward off any apprehensions that the centra flow of 360 microns can create some aberrations for a patient. It does not. And that 360 micron is that magical figure that the manufacturers and the designer has achieved, and this gives a very, very good result. It does not really create a halo, and it is all for these miles and miles of smiles that the ICL really gives us great effects. Thank you very much. I call upon Dr. Ramurthy now, and he'll be speaking to us on the IPCL. Dr. Ramurthy, of course, as the president of the AIOS, but has been one person with whom both Dr. Ramurthy and myself and Dr. Sri Ganesh, we learned phakic IOLs more or less at the same time. And we all traveled to Germany to Dr. Burkhard Dick to learn phakic IOLs. And then each of us, we changed over more to the ICL, and Dr. Ramurthy has done a very large number of IPCL. So he'll share his insights with the IPCL, which is a very good lens of Indian origin and really needs to be used by us. Thank you.
Thank you, Partha. Very good morning to one and all of you, and thank you once again for having me in this wonderful course of yours. Basically, as Partha just mentioned, we all started doing phakic IOLs sometime in 2002. 2005 or 6, we shifted over largely to ICLs, thanks to the strong recommendation of Sri Ganesh. And since then, it has been a good experience. And slowly, my preference for putting these phakic intraocular lenses inside has been increasing. My first pamphlet on laser vision correction, LASIK, way back in 1997, said minus 20 diopters, plus 12 diopters, no problem, we'll do LASIK for you. It was not because we are unethical, but because that's all the knowledge that we had. But slowly the numbers have been coming down, and today anything beyond minus 8, 9 diopters, beyond plus 4 diopters, I would rather not touch the cornea but do a phakic IOL, which offers a better quality and more stable correction of vision. But the cost is a major constraint, and because of this, there were quite a few patients whom we are forced to do a procedure on the cornea or turning them away from a procedure. I had my reservations about adapting to these lenses because these are unlike intraocular lenses which you put in an elderly population. You want to be extremely safe with these lenses for the simple reason that what you do today might far outlive your entire professional your entire professional lifetime, and has to serve the patient for about 6 to 7 decades. So you have to be extremely careful as to what goes in. So it was with a lot of reservations I adapted to this, but then I've had a mixed experience. I still continue to use both the ICL and IPCL, and as a matter of financial disclosures relevant to this talk, I'm a speaker and do receive travel support both from STAR and IOCAT, so you can as well say that I have no financial interest. So let's see what are the points in which they differ. Basically, you can see the lens prototypes over here. The earlier speakers have alluded to this. And in the dioptric range, you have a plus 10 to minus 18 diopters. Now that ICL is dispensed in balance all solution, there's no enlargement of the lens, there's no change in the power, and what's on the label is what you get. Wherein IPCL has a slightly larger range, plus 15 diopters to minus 30 diopters, but it is dispensed in saline, so the power that you finally get is slightly less than what's labeled on the lens. As far as astigmatism range is concerned, in ICL it's up to 6 diopters, in IPCL it's up to 8 diopters. Material is basically, even the ICL is made of hydrophilic acrylic, but it has a Collamer coating of 200 microns on the surface, because of which the biocompatibility of this lens is very good. The hydrophilic acrylic is the material of the IPCL. There's no coating on the surface. So that's one of the reasons that we have certain reservations about the adaptation of this lens in the ciliary sulcus, where it's constantly coming in contact with the iris. But having said that, in the experience that we have had, these lenses seem to do reasonably well. There is a central hole in the ICL, while what you have in the IPCL is a paracentral holes. I think it's a bit of a technical challenge to put this hole in the center, but what the IPCL people say is that they have put this hole not in the center but in the periphery because this is supposed to cause dysphotopsia. Having said that, significant studies based on the ICL have shown that the 360 micron hole that they create does not cause any kind of dysphotopsia, though occasionally we do have patients complaining of it. Because of this central hole which is not covered by the iris, you do not require a peripheral iridotomy, especially with the V4C model of the ICL. But in IPCL, even though there are 8 holes, 2 on the haptics, 4 on this flanges over here, and 2 over here, it's a good idea to do a PI, because in the initial cases when I shifted over to IPCL, I was not doing a PI, and some of these cases end up with raised tension, and post-operatively we had to do that. And what you have is 4 haptic pads in ICL. In IPCL, you have this 6 haptic pads, and the manufacturers claim that these lenses are more stable because of this. But my personal experience, I find that both toric ICLs as well as toric IPCLs remain quite stable once they are correctly implanted. What about the toric orientation? In ICL, as some of you might be knowing, because the lenses are not custom made for each particular eye, once you implant, you have to dial them into place. You get a chart which tells you it has to be dialed by 15 degrees, 20 degrees, etc. But in toric IPCL, because each lens is custom made for that particular patient, you just have to leave it in the 0-180 degrees. No rotation is really necessary. Especially when you are beginning out with cases, this is a significant advantage for the simple reason that the exact orientation, the exact marking might be a challenge, though once you have done a few cases, it comes naturally to you. As far as the size of the holes is concerned, I already mentioned 360 microns is the size of all the holes. In this case, it's 5 holes that you have. In this case, it's 8 holes, all holes being 400 microns, though schematically these holes appear to be somewhat smaller. And a very important point that you need to remember is that these two holes actually on the haptics do not serve any purpose of the fluid coming from the back of the lens to the front, but they are purely marks on the lens. Actually, the original V4 lens, these were not holes, but they're just marks over there. So these holes do not serve any purpose, but this mark is on the leading right edge, while in the IPCL is in the leading left edge. So one of my consultants, when he was shifting over to ICL to IPCL, with great difficulty, he placed the IPCL with the leading right edge over here so that the lens was inverted. So please keep this in mind that when you are using both these lenses, the orientation of these lenses are slightly different. So again, as I said, it's dispensed in the V4C model is dispensed in BSS. So the power of the lens is what is labeled over there. Here it is in saline. So over a period of 1 to 2 days, the lens expands in size. So the power comes down. The sizing of the lens also changes slightly in 24 to 48 hours. As was very nicely shown by Partha just now, the ICL loading is a bit of a challenge. And initially we used to say that if you have done a correct loading, 50% of the job is done. And it is doable. Once you have done about half a dozen cases, about 20 cases, you get quite comfortable doing it. In my case, actually, it's our sisters who do this because they are doing it quite often. But initially, you have to learn the technique of loading ICL. I think it was shown very nicely by Partha just now. And in the case of IPCL, it's very similar to loading a plate haptic ICL, a plate haptic intraocular lens. So most of you, since you're doing intraocular lenses, it's much more easier to adapt to this. And then what about the optic size? You must remember 1.25 times is the number on the cornea that you get on the of the optics of the lens. That is, if you have a 5 millimeter optics of the lens, effective optic zone on the cornea equivalent to what you get with the laser vision correction is 6.25. So the higher the power of the lens, smaller is the optic zone size. And what you get with the ICL is in the range of 4.8 to 5.8 with an overall diameter of 11 to 13 millimeters, 11, 11.5, 12, 12.5 and 13. And what you have over here is 5.75 to 6.2 and 11 to 4 millimeters, 14 millimeters. More importantly, when you have large scotopic pupils, that you find that you have a young patient, high myope with a 6.5, 7 millimeters, customization of these lenses is possible. You can specifically order for the lens to come off even of a 7.5 millimeter optic size without an increase in the overall diameter of the lens, so that the sizing of the lens remains the same as what you would calculate normally. And secondly, as far as the power of this lens is also concerned, more extreme power. Is my time up or what?
Yeah.
My God. Okay. So I'll just go on to a quick video. This is a IPCL being loaded. You do not require any viscoelastic. Usually it's just saline or BSS that's used. And over here, I place the lens over here. As you can see, the cartridge looks very similar to what you use with intraocular lenses. And this is the IPCL being loaded over there. So it's extremely easy for any one of us to adapt to it. But it's an extremely soft, pliable material. And it's not a good idea to use viscoelastic. You inject under just normal saline or BSS, and that's the lens being placed in the cartridge, the lens edge being brought to the, and you can see the markings over here. Basically, you do it at 0, 180 degrees. You can introduce these lenses to 2.8 millimeters, but for better control, I like to make a 3 millimeter incision so that the mouth of the cartridge is inside the anterior chamber. I get a better control. And that's the IPCL, which is being injected inside. And you can see, and it's important that these two holes over here are superiorly placed. And this gets covered by the lids, because of which the amount of dysphotopsia is supposed to be even less. So basically, the leading edge should be on the left leading haptic, and the hole should be on the left leading haptic, and these two holes should be superiorly placed. Once you have placed the IPCL in place, then you evacuate all the viscoelastic. And as you can see over here, this lens has been oriented in the 0, 180 degrees axis. There's really no need to turn these lenses around. Nowadays, we implant all these lenses under Varion guidance. This is completely compensated for cyclotorsion. This is a digital imaging which comes onto the corneal surface, which gets projected, which is acquired in the OPD. And otherwise, the procedure is exactly the same. And you can see the 0, 180 degree orientation, making a slightly large opening, then the IPCL being injected. Otherwise, the rest of the procedure is exactly the same. I'll move towards the end of the video, where you will see that the orientation of this lens is easily helped by the overlay that you get. This is of course of help even in situations where you're doing a toric intraocular lenses. As you can see over here, these are the two holes which are on the superior side under the upper lens. And just in case, these are some of the features of these lenses. As I already said, there are 6 haptic pads, and it's supposed to ensure better stability of this lens. And then again, you have these small holes, especially on this angled haptic vault. Because of this angulation, the clearance from the surface of the anterior lens is supposed to be even better, and this is supposed to assist in better filtration of fluid from the back of the lens to the front. And all these edges are rounded, and because this the aberration on the surface of the iris, release of pigmentation is supposed to be less. These are our experiences also. These lenses, once rightly implanted, appear to stay absolutely quiet. And the presbyopic IPCL model is also available. There are a few surgeons in India who have tried this out. I personally have not yet used them. They are available from -10 to +6 diopters, and with all these additions over there. And George Elio is one person who seems to have used these lenses with in significant numbers and reports a good experience with this, but obviously a good modality to address presbyopia. So a very short presentation of the study we conducted with these lenses. It was a retrospective case series conducted in our hospital in Coimbatore. It was a duration of 1 year, July 2015 to June 2016. And 108 eyes of 61 patients were this is actually being presented in ASCRS also this year. And total eye studies were 108. Keratoconic eyes, especially once they are stable, because the patient is beyond 35 or 40 years old, or once CXL has been done and the cornea is stable for about a period of 1 year, we go ahead and do this. Post CXL in 12 eyes and post DALK in 2 eyes. The remaining was basically myopic astigmatism eyes, including amblyopia and 15 eyes. And the parameters that we studied were UCVA, BCVA, and intraoperative and postoperative complications. And as far as the sex distribution is concerned, a little predominance of females, and majority of the patients, as expected, were in the age group of about 20 to 30 years. Toric ICLs or toric IPSCLs is most often what we prefer, but even because you use this costly technology, and even if you leave behind about 1.5 diopters of refractive error uncorrected, these patients are not happy. So anything beyond 0.75 diopters, I tend to go ahead and use an IPCL. Otherwise, if I'm using a plain IPCL or plain ICL, I position my incision to take care of the whatever astigmatism is there. The spherical equivalent of the error treated was -2 to -23.25 diopters. As you can see, extremely thin corneas, even which had undergone CXL for keratoconus, were part of the study. As far as visual outcome, acuity outcome is concerned, at 6 months post-operatively, 87% of the patients were within 0.5 diopters of their refractive error. 97.2% of the patients were within 1 diopter of their residual refractive error. We did experience initially, because of our hangover from ICLs, we were not doing a peripheral iodotomy. In these patients, we found that 4 eyes had a raised intraocular pressure. Just last of my slides. In 2 eyes, we had to put them on anti-glaucoma medication. 2 eyes a YAC-PI. But otherwise, once this was done, these patients seemed to recover quite well. We had to rotate these patients into the right position in 3 of these eyes. 2 eyes developed a limited cataract which did not require any treatment. This is the comparison between the FDA study on ICL and what we found in IPCL. The results were quite satisfactory. To conclude, basically implantation of IPCL is a safe and effective procedure for refractive correction, myopia and myopic astigmatism in stabilized keratoconic patients as well as in simple refractive error. Thank you so much for your kind attention.
Thank you, sir. Thank you very much. And before we start off with Dr. Sri Ganesh, let us take a few questions for the first 3 talks. So Dr. Ramurthy has to leave, so can we have a few questions for Dr. Ramurthy? Anybody wishing to? Yes, yes, sir. Can you come to the mic, sir?
The corneal thickness, even 385, you have implanted IPCL. So, what was the length of follow-up, and further measurement of the corneal thickness?
Sir, as I said, about 14 eyes in our series were patients of keratoconus who had already undergone C8, sir. So as we all know, once we do a collagen cross-linkage in these keratoconus patients, usually the measured corneal thickness comes down. So these patients belong to that category. I don't think it was 325, I think it was 380 or something.
385.
Sorry?
385 it was mentioned.
Yeah, so these were thin corneas of keratoconus patients. We do a CXL procedure, wait for a period of 6 months to 1 year, and then subsequently whatever cylindrical correction is there along with the refractive error, we go ahead and do this. And this we have been doing with both with the ICLs and toric ICLs. It doesn't take care of the refractive error completely, but debulks the amount of refractive error so that these patients get a better quality of vision subsequent to the implantation of these lenses.
Right. Thank you, sir.
While taking the measurements with the caliper, what things can go wrong? Are there any tips on the caliper measurements? Or is there any other instrument to validate the records that they have from the
This has been a controversy that's been going for a long time as to how exactly do you measure. Basically, we use the vernier calipers, which usually anesthetize the cornea, make the patient lie down, put a speculum under the microscope you are supposed to take. That's what we most often do. Even when you do it on the slit lamp and all, sometimes there's inaccuracies. So if you do that, then we also compare it with our OBSCAN or pentacam measurements. Usually what happens is we go with the measurements of the calipers, but we make sure that it's validated by the OBSCAN measurements. In OBSCAN, though it might be more accurate, if you have a small blood vessel or if you have a pigment blotch right at the limbus at the 180 degrees, that might be construed as part of the limbus and you might get an enlarged reading. Of course, a good way to do this would also be to validate it with a UBM measurement or the sulcus to sulcus measurement. Some of the surgeons do take that measurement as a medium, but then once you, in our hands at least, an OBSCAN validated with the vernier calipers works well. One important caveat is please don't go with laser interference biometry. IOL Master or Lenstar usually gives you about 0.5 millimeters more than what you get with these measurements. So this has to be factored in. For AC depth, yes, it is possible. It is possible.
AC depth best be taken from the pentacam.
No, see,
pentacam
in
gives a
smaller
very
setups, we don't have these kind of instruments, and if we are planning to do the ICL, so can we take the readings of the normal A scan to find out the AC depth? Or you can say...
Ideally, as Partha has mentioned, we do it with the pentacam or with the OBSCAN, and you also have to remember these lenses give the AC depth measured from the corneal surface. So you have to tune these lenses to measure from the endothelium to the front surface of the lens. But then if you don't have access to it, then taking with the A-scan is one of the options. Though may not be that accurate, it has to be at least beyond 2.8 millimeters.
The white to white, as Dr. Ramurthy said, is very important that you take it very well. And the digital caliper is something that we've been using for the last 3 years now. Before that, we used to use the OBSCAN, which repeatedly gave very good results. Any of us still using the OBSCAN? Anybody for the white to white?
I use the OBSCAN.
You use the OBSCAN, yes.
I use but in the OBSCAN you have to use the iMetrics.
Yeah, the iMetrics.
Software of the...
Yes. So the OBSCAN definitely gives a very good result, but it's not now very much in use. So, but the caliper, the digital caliper is excellent. And this is one aspect that has to be done extremely well so that you get the proper dimensions. Any other questions to Dr. Bhasin? Any questions on the workup? Yes, sir.
Most of the persons, they are not having pentacam. So as he was asking, only with the help of a scan, can we do all the pre-operative measurement for IPCL?
I think only the anterior chamber depth can be seen by this, and corneal pachymeter also should be there, whether it is ultrasound or by the topography or by any other means or OCT. So we have to measure the corneal thickness also. That has to be reduced. If it is too less in some cases, that has to be reduced from the anterior chamber depth, which is measured from the anterior corneal surface.
Yeah. So corneal thickness we can know by any pachymetry there.
Corneal thickness can be seen by various means.
Yeah.
You can do a simple ultrasound pachymetry, or with the pentacam, or with the OCT also, anterior segment OCT also. You
Right.
can measure that.
Right, sir. Thank you.
So I think now we will come to...
Can I ask a question, sir?
Yes, go ahead.
Yes,
Yes. Yes, tell.
Yeah, I have a patient who is opting for ICL rather than ICL. So her AC depth is 2.76. And we have
From the endothelium.
Yes, we have done it 4 times because for the first 2 readings, the star has refused to supply because her depth was 2.76. They said that it has to be minimum 2.80.
2.80.
So in that situation, what do you do? She wants only foreign lens, that is star. She doesn't want to go for the Indian.
You can put it as 2.8. You round it off.
You round it off to 2.8.
Yeah.
I personally have done it, for your experience, from up to 2.75 millimeter of AC depth.
Should we press them to supply it as 2.80 because the company has refused to supply?
You can round it out to and say that it is 2.8 to them.
Okay, that won't be a problem.
Yeah.
See, my cutoff is 2.7, but there are like many people like Shimuzu's cutoff is around 2.6.
Okay.
So depending upon your experience, especially with the V4C, which has the center flow, you can use lower volts and lower ACDs. So it's okay, but only thing star will not supply it. So you need to just put it at 2.8 so that you
Okay. Okay. Thanks.
Thank you. So we come to our next topic, and that is challenging cases in phakic IOL. And no better person than the hero in phakic IOL, and that is Dr. Sri Ganesh. He'll take us through all the challenging cases, but let us first understand that what these challenging cases mean to be and when can you actually take up. So Sri Ganesh, don't show the challenging cases with the view that each one of us can go on to the challenging cases. It's only when you're seasoned enough as Sri Ganesh that the results will be as good.
Good morning, dear friends. Thank you very much, Partha, for inviting me to this IC. I've been part of this IC for as long as I can remember from when he has started, and it's a pleasure being here. So coming to challenging cases, yes, we all started phakic IOLs around the same time, 2002, 2001. ICLs, I've done about 5,000 of them, and we have had our challenges. And what I'll be showing you is I'll just be showing you a couple of videos, 2 cases, because we don't have much time. 2 very interesting cases, special situations, and then how I dealt with them. The first one was a hyperopic ICL, which I implanted for a high hyperopia, almost about 12 diopters of hyperopia. And after a year, this patient came back with anterior subcapsular cataract. And then I had to manage this. The IOL power required was almost about 52 diopters or so. And then for which you don't get the lenses. So the option was, one is just explant the ICL and then put in a piggyback, but then I decided to do something different. I call it phaco with ICL in situ, and I will show you the video of how I went about this case. I don't have any financial interest in this talk. This is, you can see the typical anterior subcapsular cataract. So I'm entering with a 2.8 mm incision, and then here I decide to retain the ICL as a piggyback and put a standard IOL. So what I'm going to show you is how to do a phaco with the ICL in place. So what I do is the trailing haptics are lifted into the anterior chamber. I inject viscoelastic under the ICL, and after that I'm doing a rhexis. So aim for a 5 mm rhexis. This is a young patient, so if you are not able to get a good rhexis with a needle, you can also use a forceps. Here I am using a needle, and then I also use the forceps. Usually these cataracts are very soft, they are young patients. And for hyperopia, this is something that can be done. This patient actually was quite unhappy when I told him that he had developed a cataract and that we need to remove the ICL because he had paid for the ICL surgery and it was just about a year and a half. So he was very happy when I told him that we'll try to retain the ICL and remove the cataract. This is a hydrodissection. And then here I'm going with the IA, coaxial IA, because the cataract itself is very soft. So I just remove the soft nucleus and the cortex with IA. You can see the ICL is there, but I put in viscoelastic between the ICL and the endothelium, so it doesn't touch the endothelium. And there is a space there where you can work. And that's the cortex being removed. In fact, the endothelial loss may be even less because this acts like a HEMA hood. Dr. K.K. Mehta has had a presentation on the HEMA hood for endothelial protection. And some of you all may have seen that. So this basically prevents the fluid from going and hitting the endothelium. There's viscoelastic between the ICL and endothelium. The visibility is quite good through the ICL and you can do a thorough job of removing the cataract. After that I used a standard 22 diopter lens because it's very difficult to do the IOL calculation. There are a lot of issues here because the final refractive outcome can depend on the effective lens position, the relationship between the ICL and the IOL, the distance between the ICL and IOL. So that is a standard 22 diopter lens which I am placing in the capsular bag. Okay, and then what you have to do is you have to tuck in the trailing haptics. The leading haptics are already in the sulcus. I just had shifted the trailing haptics into the antechamber. So after injecting the lens into the capsular bag, I just put in the, I'm tucking, see that's the tucking in of the trailing haptics back into the sulcus. There's a lot of space there and the ICL sits well. And this patient had a residual power of about 1.25 diopters and it's now almost about 4 years and this patient is doing very well. 612 vision, is amblyopic, but he's happy that his ICL is still there in the eye. And this is something which can be done. I have used the ICL as a piggyback lens for many patients. This is a second case, a 40-year-old male, high myopic astigmatism. You can see -11 with 2-cylinder. Post-op, his vision was 6/6. After 1 month, he complained of blurring of vision only in the left eye, and this was his refraction, +0.5 with -4-cylinder. And his vision had dropped to 6/18. Right eye was fine, 6/6 uncorrected. So obviously, the ICL had rotated, if you get a plus and minus. Then we checked again, this is the details, white to white was 11.4 and on dilatation we saw that there was a 70-degree rotation of the ICL, so we had to reposition it. We repositioned it again 15 days post-op, he again complained of blurring of vision, dilated, it was rotated again. And then we did a UBM, the sulcus to sulcus was very high, 12.6, and so we used 2 sizes larger and then did an ICL exchange. So this is the video. You can see that is the rotation. You can see that the ICL has rotated 70 degrees because the vertical sulcus to sulcus is larger than the horizontal sulcus to sulcus. So if the lens is loose, it automatically sits vertically in the vertical sulcus to sulcus. Here I am rotating it after putting viscoelastic. Sometimes just a rotation will help. If the patient has rubbed the eye or there's some kind of minor trauma, then these lenses can shift. If you just rotate it, then it will be okay. I thought it will be okay because the other eye, the right eye was doing very well. Position of ICL was okay. So I rotated this lens and you can see that now I have positioned it in the, now it is horizontally oriented, the axis. And then I just check and see that the axis is aligned properly. I'm just rotating through the side port. You don't have to open the main incision for repositioning the ICL. And then I just irrigate the viscoelastic outside. But watch carefully. Now what happens when you irrigate is that these myopic eyes are very compliant and the ciliary body stretches. So you can see that I am hydrating, and then watch carefully what happens. The ICL is now oriented well, and I am quite happy with the axis. I again check it to make sure. Okay, and then I think, okay, the eye is a little soft, so I think I'll just hydrate a little more, and then you can see that what happens. Okay, watch it carefully in slow motion. As hydrating, the whole ICL shifts and again goes back vertically. So this basically indicates that the ICL is loose. I had to reorder the ICL, so I just kind of rotated it, kept it in place. Then I did the UBM and found that the sulcus to sulcus was 12.6, only in the left eye. So you can have a variation. So this is what I wanted to emphasize, that you can have variation between the white to white and sulcus to sulcus. You can have variation in the fellow eye, with one eye being normal, the relationship being normal between the white to white and sulcus to sulcus. So nowadays I routinely do a UBM. There may be about 4 to 5% of these cases where you have this anatomical abnormality where the sulcus is either too small where you have a large vault, or too big where you have a rotation. So by doing a UBM and measuring the sulcus to sulcus, you will rule out these anatomical abnormalities in about these 3 to 4% of cases. So this is the ICL exchange that happened after I ordered the lens 2 sizes bigger. You can look at the technique of exchange. I just put in viscoelastic, then bring out the trailing haptics into the anterior chamber, then rotate the lens. Then I use the same lens holding forceps to grab the lens. You should hold the lens at the optic haptic junction where it is the thickest, where you get a good grip. Okay? You rotate it slightly to one side and then grab it, and then after that through the same 2.8 mm incision, you can, just by a wriggling motion, you can bring out the whole ICL. It is soft, it's pliable, it just comes out. Then you put in viscoelastic and then you inject the new ICL. The larger diameter ICL is being injected here. And that's how you do a ICL exchange. After that, once the ICL unfolds, then you can just tuck the haptics into the sulcus and orient it properly as per the axis in your diagram. So this is, I normally orient it before tucking in, and once you tuck in the haptics, both the trailing and the leading haptics, then you slightly do a to and fro motion of the body of the lens just beyond the optic. This will free up any of the haptics which are folded, because sometimes you can have folding of the haptics. They can get entrapped in the zonules, and then you can have an abnormal vault on one side. So that's the technique which I use. I just ensure that now the position is okay, and this was how this case was managed. This was a V4 lens, so the iridectomy is already there. So just put pilocarpine to construct the pupil. So these were the two interesting cases. Thank you very much for your attention.
Thank you. A big round of applause for the hero. He's really shown the heroic cases. We'll ask you many questions, sir, but at the end, Shri Ganesh. So we'll ask Dr. Maipal Sasdev to talk to us on ICL in complex situation. Sir, of course, is one of the users who have been using it for so many years now, and he's going to show us the complex scenarios where we can use an ICL or an IPCL.
Hello. Yeah, thank you very much, Dr. Partha, for having me over in this course. I've been using the ICL for more than, I would say, nearly 2 decades. It was the end 90s that I started using it. And as we have traversed as regards the phakic IOL implantation, now we have 2 Indian companies also who are giving you good equivalents which are available. So let us see as to how you can think outside the box. When you came in with the phakic IOLs for refractive error in healthy times, it was basically clear cut that this is the AC depth, etc. These are the things that need to be done and you need to implant. But let's see if we become adventurous and we can use this in situations. For example, what is now being seen is that a patient of corneal ectasia, whether it is a primary keratoconus or a post-LASIK ectasia, these patients are obviously most difficult to treat at one given point. But nowadays, with the modalities that have come in, they are becoming amenable to treatment, and I'll just show you how the ICL helps you. The second thing is that what is known as bioptics or trioptics, wherein you combine 2 or 3 refractive procedures to get the patient to the desired result. Bioptics is typically done when the refractive errors are outside the range of each single procedure. So you can combine these procedures and get good results. And then you can look at residual refractive errors in case of IOL surgeries. Now, when you are looking at post-corneal ectasia or post-keratoplasty, what is important in this is that the indications would be that the topography of these patients needs to be stable. And it is preferable if the stability is for at least 1 to 2 years. So if you have a stable topography, you have a stable refraction, then you can go ahead and look at doing the ICL in these particular cases. The advantage is that it would give you a stable ametropic compensation, and it would preserve the accommodation for an individual. So instead of going in for a toric IOL implantation, if the lens is clear and you have stability, because keratoconus obviously or post-LASIK ectasia happens in patients who are young. So this is what you need to do when you are looking at combining procedures. That the first thing is that you have to stabilize the primary problem, that is the problem of the keratoconus, by doing a CXL. So let's see. In this particular case, a case of July 12, patient had 6'9" coming to 6'6" with pinhole in the left eye. You can see that the vision was only finger count 1 meter. This is the unaided pinhole improving to 6'12", and when you looked at the refraction, you could see that despite this refractive correction, the patient was only improving to 6'12". So when you look at the topography, this is what you see. You can obviously see that there is a mild ectasia that's happening here. And in the left eye, you can see that there is a significant ectasia that has happened. So what essentially was done, that hypotonic cross-linking was done, and 6 weeks post-operatively, you can see that this is the refractive status that the patient has. Now, what are the options before you to correct this huge amount of ametropia that the patient has? Either you can put the patient on contact lenses, or you could try to reduce the cone by doing an intax, because it was early days. And now what I personally do is that I would do the intax and the cross-linking in one sitting. I would not first cross-link and then do an intax, but I would rather do both of them together, because the intax would work better on a flaccid cornea rather than a cornea that has already been made rigid by a cross-linking. So that is what you need to do. Or you could look at doing the DALC or PK. So let's see in this particular case, this is the intax that has been done. So this is in November. So this is the intralase, and you can see that this is the channel that is being created. Once the channel has been created, this is the side cut that is there. I'll just take it a little forward. You can see that this is the channel, and this is the clover leaf spatula which is being used. You can see this is the intax that is being driven into the channels, and you can see that this kind of completes the procedure of intax. Let's show you the picture. So this is what you have. Post-operatively, you can see that the residual refractive error that was there has gone down significantly, though there is a slight increase in the cylinder from -3 to -4. But what is important is that the BCVA in this patient has gone up to 6'9". If you remember the earlier slide, the BCVA was only 6'12". So you have had symmetrization of the cornea. which has happened with the intracorneal ring segments, and you can see that this topography, the cone has flattened, and this is what is important. So now you have a situation where you have done a cross-linking, you have done an intax and the patient obviously had a LASIK done earlier. So you had a LASIK, you had an ectasia, you have done cross-linking, you have done intax, and now you go ahead and do an ICL in this particular situation. So you can see that this is the patient. I won't bore you with the total procedure of ICL because all of you have seen. So you can see that this is the ICL, which is opening nice and gently. The AC depth is obviously great in these cases of keratoconus or corneal ectasia, and you can see that this is the ICL and that has been implanted. So let's see the post-op picture. So you can see that this is kind of stretching the limit and doing multiple procedures, and you can see that what you have is at the end of the day post toric ICL, you have a 1.5 cylinder and a vision going up to 6.9. So this is again thinking out of the box. The second thing which you can do routinely is called as bioptics. So when you do bioptics, essentially it is normally said that you should do an ICL first and then go ahead and do a laser vision correction. Earlier conventional teaching was that you make a flap, wait for at least 4 to 6 weeks, put an ICL, relift the flap after 3 months when the stability is there, and then do the laser. Nowadays people say that the suction is gentle and also you need not make a flap, but typically that's what was said. And you can see in this particular case, I'll just show you, this is just the loading of the ICL. You can see that all that I want to show you here is, can you see this? This is a flap that has been made already with no laser that has been done. So that is what you do. You put the ICL, refract the patient after 3 months, and go ahead and do the laser vision correction. So what I prefer in this particular case is that I would put only a spherical ICL, because A, you are not bothered of any rotation, and B, it is cheaper for the patient. So if there is a small refractive error which is there, say a cylinder 2, 3 or whatever it is, that is more amenable by a laser rather than just doing on a ICL. So that is my thought process, that I will put a spherical ICL, make the flap first, put a spherical ICL, and whatever is the residual power that you have, you can go ahead and do this. And this is finally something which is for correction of residual refractive error. You have all heard of the sulcoflex, which is a lens which is a faking, but typically a sulcoflex lens is said to be put when the first lens is in the bag. So in the situation that you have something which is in the ciliary sulcus, an ICL can be done. One, sulcoflex range is very limited. I think it comes up to a correction of -5. So I think it comes to -7, which comes to -5. So A is that you will not be able to correct the total thing. B, it is thicker than the ICL. So the ICL is much thinner. And C is that the hole in the center of the ICL would allow to keep a gap between the two IOLs, and therefore the chances of ossification would go down. So this is what you have as this thing. So I'll just show you. This is a child. I had done a cataract surgery when she was 3 years old, and that's about 17 years ago. And so you can see pseudophakic patient. So all we need to do is that you just go ahead, do the, so I'm just doing a spherical correction. I'm not doing a toric correction in this. So it's just a spherical ICL. So all that you have to do is that you can go ahead, but there are few synechia which are there. So you need to separate it out so that the ICL remains properly placed. And I need to center the lens. This was a primary cataract I did, and then I did a primary posterior capsular excess at that time. And you can see that that's the posterior capsular excess, that's the anterior capsular excess. The lens was slightly decentered. There's already a PI that is there, because when you're doing a congenital cataract, it's better to do a PI also. And now we go ahead and just implant the ICL. So you can see that this is an ICL which is going in nice and gentle and soft. So again, you would prefer the ICL to open in the chamber, and then you go ahead and put it behind the iris. So you can see that this is the end of the situation. You have the ICL on top of the intraocular lens, which is a 3-piece lens which was implanted about 17 years ago in the sulcus. So friends, to sum up, phakic IOL is an exciting option for correction of high refractive errors and for cases which are not amenable to conventional laser vision correction. So be adventurous, try to expand and try to combine the advantages of various procedures that are available, and these complex situations can be taken care of with the help of one of the technologies being the ICL. Thank you very much for your kind attention. And I'll just invite you to the annual IIRSI conference, which is in JW Marriott, Aero City, and this is on 23rd and 24th of September. Registration forms are available at the registration counter. Thank you. Thank you, Partha.
We have just about 3 minutes, and we quickly take a few questions. If there are any questions from the floor. Yes, sir. One thing that Dr. Sri Ganesh showed is how to remove an ICL. Now, what happens if the ICL has turned upside down? That is one very major concern. So removal is exactly what he showed, and it can be removed extremely well without damaging the ICL at all and without increasing the length of the incision, which is usually 3.2. So it can be done extremely well. So one should not fear that if everything goes wrong and the ICL is upside down, you definitely cannot leave the ICL as it is. You have to take it out and re-inject it. Getting the ICL back to its position and inside the anterior chamber is not an option. So let us not think of it at all. It has to be taken out, reinserted the correct way. And the next part is all these patients develop cataract or will develop cataract at some stage of time. So when they develop cataract, biometry issues is not a problem. You do a biometry just the normal way, because the ICL is so thin, so it does not really matter, and the biometry that you have done with the ICL would be quite accurate and give a good value.
Sir?
Yes, please.
So for Sri Ganesh, sir, what was the ACD in your first case, that hyperopic patient?
Actually, this patient had a very good ACD. It was almost about 3 millimeters. So it's very rare to get a high hyperop with a good ACD. But this was a patient who was a high hyperop, nearly 12 diopters. He was amblyopic also, good ACD. So we decided to go ahead with a ICL. But the hyperopic ICL does not have a hole. It doesn't come as with a center flow technology. So the incidence of cataracts are much higher in hyperopic ICLs than in myopic ICLs.
Thank you.
So. Basically, you're not removing the crystalline lens. If you remove the crystalline lens, that increases the risk of RD by 6 to 8%. That's there in the literature. But maintaining the crystalline lens and just putting a phakic IOL in the antechamber or in the sulcus should not increase the risk of RD. And these patients, basically, you have to do a thorough evaluation, because most of these high myopes have some amount of retinal degenerations and are prone to retinal detachment. So we do a thorough evaluation with indentation, indirect ophthalmoscopy, and we insist that every year, 6 months to 1 year, they have a retinal examination and come immediately if they are symptomatic with flashes or floaters. So by this you can. For a high hyperop, the risk of RD is not so much, but you can have risk of choroidal effusion when you open the eye. Basically, these are eyes with nanophthalmos, with very short axial lengths. So you can have choroidal effusion, so you should be very fast during your surgery and always use mannitol pre-op. That's what I do. And that risk anyway is there with high hyperops.
But I think it's one last question.
Just one sec, just a small comment.
Yeah.
What you have to do is that basically when there is what he said, you do a thorough indirect, and if there is a lesion, I would be more aggressive in treating. If you just have a lattice with maybe an atrophic hole, the people are now saying you don't need to do a barrage laser and things like that. But if the patient is going in even for an ICL surgery, I would be more aggressive in getting my retina person do a barrage laser for that patient, wait for 4 weeks and then do the procedure.
Quite correct. Yes, quickly.
Yeah, it's not correct to say that the ICL doesn't increase the rate of the RD. It definitely increases the chances of getting RD. It's not correct to say. If you are doing anything in the AC and if you are putting the ICL inside, it definitely increases the chance of the RD.
No, is there supportive literature to say that?
Yeah, definitely we have. Definitely we have, because I have.
I think, let me clear this point. The supportive literature, we have looked into the literature that is there. It does definitely not show that there is an increase in chance of RD after phakic IOL surgery. And these are literature that have been there for quite some time. Can you specify literature that you have?
When I have completed my fellowship in the retina in year 2008, till then it was a very well-known fact. After 2008, if any changes there, I don't know that. But until up to 2008, it was a clear thing that any procedure like ICL or you can say definitely that CLE has increased chances of RD.
No, CLZ will definitely increase that, Shri Ganesh said, but I don't
CLE
think for IC.
chances.
But in any case, I think suffice to emphasize again that if there is a pre-existing lesion, that needs to be treated. Often, a good indirect is not done prior to that procedure. So if there is some degenerative areas that are there that need to be treated, but long term, even for LASIK, there is a huge cross-sectional study that it is said that LASIK does not increase the incidence of retinal detachment.
See, these are very controversial things that.
But you do see cases of post-ICL getting retinal detachment.
Yes,
it's not that we have. I have had in my practice only 3 patients so far who have developed a retinal detachment post-ICL, and that spans close to 20 years of practice in ICL.
Whether it is due to the natural progress of the retina degeneration, or it is due to the surgery per se.
That is exactly what I am trying to emphasize, that if we have done so many ICLs and just 3 cases, so even normally you would have in the normal progression 3 cases of high myopia developing, because these are patients who have a very high myopia, because you don't do a LASIK for them, you normally go in for an ICL if the refractive error is more than 10. So what you are actually dealing with is more cases of high myopia.
Yeah. Thank you very much. Thanks a lot for your participation, and thanks to all our co-speakers for their valuable time and the wonderful discussion that we had. Thank you very much, everyone.
Talk as usual. All top people here. PhD, Doctor of Divinity.